So welcome to this instruction course on a very important subject, that is the pediatric community ophthalmology. So this is titled Integrating Pediatric Blindness Relief into Existing Outreach Programs, the Need of the Hour. And for this I'm Dr. Krishna Prasad being the chief instructor. I had to call upon my co-instructors, Dr.Deepti Joshi, Dr.Parikshit Gogate, Dr. Asim Kumar Sil and Dr. Anand Vinekar to the stage. Okay. So as we all know, pediatric blindness is the menace the country is facing today. And whatever we are doing is actually very little. So we already have some relief measures in terms of government as well as non-governmental agencies trying to bring in some kind of a relief into this scene. But still, the absolute integration of all these stakeholders' efforts is still a very distant view. So this IC basically is trying to bring you the approach, what should be the approach of today and tomorrow in trying to bring in some kind of a relief into this menace of childhood blindness. So we have uh, uh, this whole platter has what is the present scene of pediatric blindness relief, and how do we actually integrate our school screening services into this, and what are the existing schemes, government funded schemes that can be integrated, and what about the LVA perspective, low vision being the major cause of visual morbidity in these population, and also the emerging menace of retinopathy or prematurity, adding more problems to the existing scene. And since Dr. I think we'll okay. Okay, we'll first have Dr. Anand Vinekar because he has to attend another assignment on some other hall. So we'll start with Dr. Anand Vinekar's talk on the perspective of retinopathy of prematurity being the important cause, an emerging menace in terms of childhood blindness.
A very good afternoon, everybody, and thank you, Dr. Krishna Prasad, for putting me up in this schedule. Sustainable ROP screening and management, this is just to touch the overview. I have no commercial interests in any of the products or software that we use. So firstly, why is ROP a problem and why is screening at the community a problem? I think other than the big numbers, the fact that suddenly the Supreme Court of India has made this now mandatory neonatal care in the July 1st, 2015 mandate makes us realize that if we don't provide for it, we are now liable. Also, there are about less than 150 ROP specialists in the IROP study showed less than 100 of these are comfortable with ROP laser. So sometime by the time this instruction course gets over, about 3 babies somewhere in our country need ROP treatment. Plus, there are these sinister forms of ROP that are being reported from our country. The hybrid ROP is one such, where because of variable levels of neonatal care, you get vasoconstriction, obliteration, and because of that, these diseases are more difficult to diagnose and even harder to treat. We also have the baggage of pediatricians sometimes saying that they've never seen a blind baby from ROP, and the seniors sometimes do not allow us to screen. As this study from North India showed, this is so far from the truth, and there are so many blind babies who visit all of us. The rural menace of ROP is only recently being understood. We have a fairly large data coming out of Karnataka state and now from others as well, where the ugly head of ROP in the rural areas is worse than what we ever imagined. The incidence of rural ROP in Karnataka is about 22 to 33%, and about 6 to 7% of these babies require treatment. So what are some low-cost strategies to recruit, screen, and then manage? So one thing that we do in Karnataka state is to use the red card. As soon as a baby is weighed, and the ayah, the nurse, the doctor who weighs the child knows that the baby weighs less than 2 kilos, the card is given out to the mother. And on the lower strip is the mother's name, mobile number, and date of birth. Using this, a project manager schedules the appointments to the closest ROP screening center, which in this case in Karnataka state is almost all the district headquarters. And this is what we get. So when we go to a particular hospital, we get mothers coming from so many other satellite centers where we are physically not visiting. The next thing we have to understand is the guidelines have slightly changed and some of the new nuances of the guidelines. So of course, this is the 2010 guidelines that is still in vogue, and in 2018, we're likely to see the new one. But what confusion has been cleared is that there's no longer a 1750 grams. It's directly 2000 grams and less than 34 weeks. And although conventionally we want to screen between the third and fourth week, the newer modification to the guideline is you can screen at least once before discharge, because the average NICU stay is just a few days. So expecting a mother to come back between the third and fourth week often misses out. As this study showed, almost 8 to 12 times is the yield if you screen once before the baby gets discharged. Also, Government of India is now truly looking at wide field imaging as an alternative for ROP screening other than just indirect ophthalmoscopy. And we've been using this in Karnataka state for over 10 years now, where we are replacing the ROP specialist with wide field imaging. Almost 400 crores of blindness burden has been prevented just in our state, and all the efforts across the country are adding to thousands of crores of blindness burden prevented by preventing blindness in these really small babies. It's also got validated now. The whole program has come under the CDC guidelines in a very extensive report that was done by the Australian government and sent to Government of Karnataka, in which they clearly say that if you go back to indirect ophthalmoscopy without documenting it, you're asking for medico-legal problems. And this was a sort of red alert warning to the powers in B, especially the government. So what are the new challenges? The cost of the camera has been one, training has been one, and then involving the pediatricians has been one. So the cost of the technology, this we already spoke about last year, so I'm just going to go quickly. This device is now under the Make in India scheme, and it's more than 18 months in the market. It's at a fraction of the cost and the size. It's much more portable, and it uses LED light and a warm blue lens to actually take these images, and it is wide field, and it's now being extensively used, more than 25 installations in the country, in many states, and even a few Southeast Asian countries as well. The training of who's going to take these images and how is something that still needs to be worked on. And this is one of the initiatives where we have some very senior ROP people headed by Dr. Azad and Dr. Dogra, who are part of the mentorship program of this. So the entire training program is now going online, and anyone who wants to be trained can actually do so by actually staying in his or her own home state. In Karnataka, we are focusing on training nurses, but truly this is for physicians and non-physicians as well. As you can see in this video, this is of course a dummy video, but that could be a nurse, and he or she is correcting his or her stance, her skill, the ability to take the image remotely with the mentorship of the resource faculty or the facilitator sitting somewhere else. And this is now extensively being used in Karnataka state, and in fact that's a presentation in another hall. Now, since I was also asked to touch on management, I'm just going to talk about 2 or 3 salient things. First of all, management means prevention and treatment. So in prevention, we must involve the pediatricians. And as this report from rural Karnataka showed, if we do not have a supportive pediatrician, not only the incidence of ROP is higher, but the severity of ROP is so much worse than centers where we have a good pediatrician. And so we had to score who's a good and who's a not so supportive pediatrician, and it's a score of 10, and a score of 7 or higher actually means there's lesser ROP. Also from rural Karnataka, we showed that if neonatal care practices improve, you are not only able to reduce the severity of ROP, but also the incidence of ROP in just 1 year of intervention. And this has been a community intervention that the neonatologist colleagues of ours did. And this is the severe zone 1 that we saw before they had neonatal, they did not have good neonatal care practices, and then just going back. Of course, this is a pediatrician's topic, but I just borrowed this slide from them. So prevention of prematurity is such a difficult task, but antenatal steroids to mature the lung, judicious use of oxygen, postnatal nutrition because weight gain is so important, and finally the judicious use of blood transfusion. But as ophthalmologists in ROP, we should know these. This is the biggest challenge. Even forward states like Tamil Nadu and Karnataka don't really have blenders in all the NICUs, but the government is seriously looking at acquiring them, and I think we'll see a sudden drop in ROP severity once this happens. Which laser? Of course, the study showed that the green laser is probably better than the diode, but important thing is how do you deliver this laser? And I don't mean laser indirect ophthalmoscopy, I mean where do you deliver it? The best place to deliver it is in the NICU by the local specialists. When we started the program, it was hard to have somebody do the treatment in places like Bidar, Gulbarga, and other backward districts, but today, at least every 4 or 5 districts has a treater, and we are fortunate to partner with senior institutes like the MM Joshi and other hospitals in Shimoga, where we don't even need to go or the baby needs to travel, and the babies get taken care of there locally. Also, the baby does not have to be removed from the incubator wall, and this is something we must educate our pediatricians that we can treat the baby through the wall itself, and this would mean that the sick baby can also be treated. I'm just going to show you a time-lapse video of what happens when we give an anti-VEGF. It's becoming more and more popular. Yes, it is effective and in select cases probably a good choice, but recurrences happen and recurrences happen very late. And if we are not following up these babies, as is unfortunately the case in many times, then the child will come back with a stage 5 because initially the disease would seem to have gone away, doing much better, but unfortunately the follow-up is not good enough. As you can see here, after something like 12 weeks of giving injection, half-dose adult Avastin, there is a recurrence. In fact, there is a vitreous hemorrhage. And if you don't pick this up and do a laser or
I think till that thing gets sorted out, I think we'll have Dr. Parikshit Gogate, who is a very dynamic pediatric ophthalmologist and in the community ophthalmologist of repute, practicing in Pune. And he's known for his school screening programs, which have really led the way and has shown the way for all of us. And he will be talking on integrating the school screening programs very effectively into the community pediatric ophthalmology scene. Dr. Parikshit Gogate. Can we have the slides of Dr. Parikshit Gogate? So by which you can probably imagine that anything related to pediatric ophthalmology is difficult at the community level, including the PowerPoint presentations.
Thank you, Dr. Krishna Prasad, for giving me this opportunity. It's always a pleasure speaking on this course for the last 4 or 5 years at the All India Ophthalmology Society. And this time we are privileged and lucky to see so many senior ophthalmologists from Bangladesh who have come to hear our presentation. When we look at school screening, a very senior community ophthalmologist had once said that school screening is, it's like the story of Akbar and Birbal. So Birbal, who was Badshah Akbar's prime minister and a very wise man, he found a man was trying to look for a ring under a lamp post. So Birbal asked him, what are you searching for? So he says, I'm trying to find my ring. Where have you lost your ring? Oh, I have lost that ring somewhere in the bushes there. So then why are you trying to look it below the lamppost? Well, because perhaps there is more light here, so I will find it. So according to some, school screening is like that we are trying to look children because they are so easy to find and perhaps blindness is somewhere else. Well, actually, that is not the case. In some ways, now this is fairly dated data, almost 16-year-old data done by Dr. Murthy. When we looked at refractive errors in urban children, if you will see the difference between unaided visual acuity and the best corrected visual acuity, hardly about 15 or 20% of children who actually need specs were wearing specs in urban areas. When we look at the same study, when you look at data from rural, if you will see if here the percentage of children having vision less than 6/12 is about 6.5 to 7%. Here it is just 2.5 to 3%. But again, there is a huge difference between unaided visual acuity and best corrected visual acuity. And we know that refractive errors are still the commonest cause of visual impairment and amblyopia in children. Yes, as surgeons, we talk about pediatric cataract, we talk about ROP, and each cause of pediatric blindness is very important because each child is important. We know on each child depends the kind of the survival or the future of his family, of his community. But by far, the most common cause of visual impairment in children has always been refractive errors. Perhaps because they have been so easy to treat, we have not paid enough attention to them. And also perhaps as ophthalmologists, we believe that refraction is something that has to be done by our assistants, our optometrists or our ophthalmic assistants. And therefore, this was not given the due importance that was needed. Now we know school screening is easy, it is relatively cheap. The children are a captive audience and it's easy to do a follow-up. And I am sure everybody who's sitting in this room has taken part or supervised a school screening at some point of time. In fact, one of the first things that we do when we join ophthalmology residency is we are sent off to examine children in a school where we look for refractive errors and sometimes specs are given. So we all agree that it's a very easy way to reach children, and now earlier 20 years ago, the school enrollment ratio in India was not very high. But now with Sarva Shiksha Abhiyan, in most districts of the country, even in some of the poorest and the most, you can say, backward parts of the country, like Bihar or Jharkhand, the school enrollment ratio is now almost touching 90% because of the midday meal scheme. So all children nowadays do come to some form of a school. Yes, there is still a question as to how much they actually learn in that school, but they definitely come to the school. We had done a study in Western Maharashtra when we had examined more than 70,000 children almost a decade ago, and there we had found that nearly 10% of urban and 5% of rural children had a refractive error. This was partly done in the Satara district and partly in the Solapur district. Again, with the view to this, the Orbis International had set up its Indian Childhood Blindness Initiatives, and in which now they have almost 36 centers that are there in 19 Indian states. And there is a program perhaps far more advanced in Bangladesh in the last 10 years. And almost 10 lakh children, more than 1 million children have been treated, and nearly 100,000 pediatric cataract surgeries have been performed. Again, when we look at the approaches that were used in this childhood blindness initiative, the most common one in which maximum number of children that were seen, this is data from H.V. Desai in the last decade, is again of course school screening, followed by outreach camps, pediatric eye centers, schools for the blind and vision centers. Now each one of these approaches has perhaps a different target population. If we want to look at ROP, of course we have to go to NICUs and pediatricians. If we want to look at really blind children or severely visually impaired children, we have to go to special schools, the special schools for the blind. But if we want to generally look at the large mass of children that are there, then schools are the best one. 10 years ago, we were doing a lot of outreach camps hoping to target out of school children, because we know children of migrant communities, children living in very remote areas of tribals, of workers who go from one place to another, nomads may not be there in the regular schools. But nowadays, there are a lot of schools which are exclusively devoted to this kind of children. So even these kind of children are nowadays easier to reach. Again, one of the major problems with school eye health programs is that some programs only prescribe spectacles. So at the end of the day, what they give to a child is just a piece of paper with the child's prescription written onto them. Well, some others, and this is becoming more and more common, also dispense the spectacles. But again, the question is whom to dispense and how much to dispense. We know that by the WHO's norms, a significant refractive error is a refractive error more than +3 or more than -1 or a cylinder of 1 diopter or above. And there is a beautiful booklet that has come out last year with Orbis and Sight Savers International from the International Center for Eye Health, London, as to how to have guidelines for school screening. Generally, this concept of significant refractive error comes in is that if this much is the refractive error, the child's unaided vision will be less than 618, and if we don't treat such a refractive error, the child is likely to become amblyopic. But again, in a lot of the school screening programs, a problem that has been seen is there is over-prescription and dispensing. A lot of children are dispensed or prescribed or dispensed spectacles which are 0.25 or 0.5 or a zero point 0.5 cylinder. There are two reasons why this happens. One is, of course, we all know it is unnecessary, but suppose the program is with help of an optical chain or with someone who is in the optical business, and they would want more spectacles to go. Also, when we had done an audit of the District Blindness Control Society of Pune had given almost screened 40,000 children and given more than 2,000 spectacles under the Sarva Shiksha Abhiyan. Well, the more spectacles you give, more is the target that you have achieved, more is the work that you have done, more are the funds that you would get from the government or the Rotary Club or from a donor or a funder. So even though it is unnecessary, well, it breeds kind of a false success. And of course, there is also an unnecessary cost that is there. And the cost is not just for the government or the donor or the funder. The cost is partly also there for the child and the family, because many a times the first spectacle is given free. But then when that spectacle breaks, a lot of parents would say, oh, my child has specs, so now they will go to a local optical shop and try to get another pair of specs. And here perhaps since Dr. Asim and I have signed a confidentiality, we cannot, that data is not there. But we had done an evaluation just 10 days ago in Tamil Nadu for a large INGO project. And there we had found that good free spectacles were given. They got broke about 3 or 4 months later. And the father went to a local optical shop and they had by mistake put a bifocal specs in that child's test. And the child was insisting that he cannot see with that specs. But his teachers and his parents were insisting that he has to wear these specs. So when we had gone to check the compliance visit and we found as to why the child is not wearing specs, child was telling, I do not see well with these specs. And the child was in one eye wearing a bifocal spectacle by mistake. So when there are no quality checks, or even if there are quality checks, something like this can happen. Well, finally, of course, when we talk of a refractive error program, the very important thing is compliance. What is the use? So I have time, no? Yeah. What is the use of finding a child with specs, giving the child that specs, if the child is not going to wear that specs? So compliance is a major issue. Spectacles can correct the visual deficit of refractive errors only when they are worn. If the child does not wear the spectacles they have, all the efforts to correct the refractive errors have come to a naught. And the proportion of children who would benefit from spectacle corrections and yet do not owe or wear glasses has to be found high in almost most countries in the developing and the developed world. We had done a study in Pune, a spectacle compliance study, in which we had gone after 6 months when spectacles had been given free of cost by the District Blindness Control Society, and the schools were visited without any prior intimation. And here the students were actually checked if they were wearing the spectacles that were dispensed. And if they were not, the child was asked if he or she had the glasses in his or her bag, or whether they were at the child's home, and what were the reasons for not wearing the spectacles. So when we look at it, school screening, is it worth it? Is it worth spending the amount of money that we are doing? Is it that we are looking under the lampshade just because it's easy for us to do? Does giving the spectacles actually help the child? Well, the answer to all this is yes, it does help the child. The child's visual acuity improves, the child's vision function improves, and we have data from Pune, and there is a lot of data which is coming from Nathan Congdon studies in China, is that the child's academic performance also improves. So when we are looking at the spectacle thing as far as schools are concerned, let us sell it to the schools not as a healthcare or an eye care activity, but let us sell it as an educational activity, because all the school, the entire school structure, the teachers, the principals, the boards, everyone wants that the children's results should improve, because that is against what they are gauged in. So if we can tell them that if a child wears specs, the child will see better, and perhaps the child will do better in school, then there are more chances that the child is going to wear specs. Again, when we are looking at school screening, we also look at the Anganwadi screenings because they form the backbone of India's preschool system. It's 0 to 6 years of age. And well, while they do preschool education, vaccination, midday meal, and helping pregnant women, most importantly, they are the most important kind of link people if we want to go to do anything with preschool children. And we know that amblyopia develops in the first 6 to 7 years of life. And if we have to do something to prevent that amblyopia, then screening Anganwadis has to be done. The problem for Anganwadi screening is that many pediatric visual acuity charts are very expensive. So if we can design handmade charts, and nowadays there are a lot of indigenous Indian versions that are coming, then a lot of children can be screened actually much, much earlier. We had tried to do it with help of sweets and to see if they can be used. But again, the main problem is that for Anganwadi screening, examining infants and toddlers is not easy. Examining their vision is not easy. Most of them do not complain of visual problems, even if they are identified where to refer. And again, the prevalence of blindness and visual impairment in preschoolers is very, very less. But then it's an excellent way to reach to them. So in Pune, in the last 5 years, we have screened about 75-80,000 children. We have given spectacles to all of them. And in this, we have reached out to a lot of children in special educations for the blind, schools for deaf mute, learning disabled, physically handicapped. Because in all of them, prevalence of refractive errors is about 3 to 10 times higher than normal children. So in children with learning disabilities, in children with visual impairments, even migrant workers, out of school children, children who have undergone surgery. One last one is, if we look at the school screening, we do find, say in each school which has about 500 children, at least one child who has vision less than 3/60 or 6/60 and needs an intervention. The major problem in most places is convincing these children to come from the school to the hospital. And that is the linkage that needs to be strengthened. And for this, Orbis International has launched its REACH initiative, in which Dr.Sil's place is one of them. And they plan to screen almost, how many, 5 million? 4.5 lakhs. Yeah, in your this. Yeah, so in 10 such centers, so total about 4 to 5 million children all over the country. And there they are using a lot of new technology, and for the first time they have put in a lot of quality control measures to make school screening more effective. But since it's on way, well, we cannot comment on that. Thank you.
Parikshit, just what is the commitment of the institution as a whole? Like when you have screened the schools, what is your experience? Is the head of the institution or the board or the committee which oversees the school, are they sometimes do they really cooperate with you all the time, or their whims and fancies also come in the way?
It differs, but generally we have seen that children which are run by, the schools that are run by a trust or a NGO are more likely to be committed. Like in Pune, we work with the Anjuman-e-Islam group of schools. So there, and a lot of them are mostly girls' schools. Because their management is very, very committed, they will see to it. If we don't visit them for 6 or 8 months, they will call us again. So generally, NGO-run schools or those who are run by a trust, run by missionaries or some kind of a zeal, they are more cooperative. If we look at purely the Zilla Parishad, the district administration schools or the municipal schools, a lot of them have a very like a government approach because they know their salary is going to come. They believe that they are already too much burdened by doing other work, like the government puts them to say election duty or things like that. So they consider this an extra thing that is done. But again, amongst all the eye care centers, perhaps the Arvind is the smartest. So the Arvind Eye Hospital has started a new program. So like you have school children eye screening program, they have now started school teachers eye screening program. So whenever they go to examine school children, they run a parallel this to examine school teachers. And they try to give presbyopic specs to school teachers, because if the teachers themselves understand that wearing specs is making a difference to them, it becomes easier for them to convince the children.
But is there a mandate that there should be an annual eye examination by the government of India?
No, there is, I think Asim is a part of the Vision 2020 committee. So,
No, annual eye examination, there was a suggestion that before school enrollment, can government make it mandatory to have a vision check, visual acuity check before enrolling into the school? But that is against, again going against the Right to Education Act. You cannot deny any child. So,
but a lot of private schools, corporate schools, and trust schools do have a visual check at entry at the age of 6 years. It's there in a lot
yeah,
of schools.
it is
in
there,
Maharashtra.
but government cannot make it a mandatory rule because that goes against the right to education.
But at least it can prompt them for a screening. I mean, that will be a window of opportunity for people who can probably.
No,
Yeah.
Karnataka, we have made a Karnataka specific school eye health policy in which we have incorporated one column in the admission form of the school, visual status. Okay, it has to be entered. Not that the children who don't get it entered will not be admitted, but it is better. Suppose they see a column in that form, they make an attempt to go to the, let it be from any refractionist also. Let the visual status may be mentioned. Like that.
Okay, so that there is some prompting.
There is
okay,
some
they are
prompting.
sensitized about it.
As doctor was telling, we cannot make it mandatory. As it school admission is not up to 100%. So we can't expect all government children to get this.
But I think people like Dr. Parikshit or such institutions can use that opportunity. You can probably at the time of admission, you can even probably there will be more cooperative for screening, because that becomes a part of a requirement.
Yes. And I wanted to ask you one question. What was the most common cause for non-compliance by the children for not wearing spectacles in school eye screening?
one is of course broken or lost spectacles.
Okay.
Other than that is teased about spectacles.
Yeah,
So that is
okay.
a very important cause.
And I have also done this exercise, and I found that even the parents discouraged girls from wearing the glasses. That was the most common. I called all the children on the dais to tell their problems, and so I think sensitizing the parents also is one of the most important.
So in the REACH study, they have a lot of these
you.
issues have been addressed. They have written booklets in Bangla, Tamil, which are given to the child and the child's parents.
So
when the specs are
what the
dispensed.
easiest solution I have found is I normally spread the sort of a myth or whatever fact to say that the children with a higher IQ not develop a spectacle
No,
number.
it is not a myth. There is a
No.
serious this. I am not having a refractor. I'm a presbyope. But then myopia is associated with higher intelligence quotient.
No, that's what.
There is a
fact,
lot of evidence
if it can
to
be
it.
perpetuated, can be probably spread among the children. Probably it becomes a matter of pride to wear spectacles. You know, probably the business of overall optical shops will improve. Because
And there
lot
is
of
a
children
very this to it. Studies all over the world, not just from Pune, but Mexico, Tanzania, Europe show that girls are more likely to wear specs than boys. And according to the psychology journals, the reason is that if you wear specs, it marks you out in the class. So a lot of the ladies would want to do something, so they stand out in the class. But because a lot of boys are boisterous or they do some masti, if he is wearing a specs, it's very easy for the teacher to point him out or to find him out. So that's why they don't like it.
But
That's another
not
risk.
later. I think the refractive surgery business probably will be working the different way. Okay, thank you so much, Dr. Parikshit.
Sir, I
for-
have a quick question.
Yeah, please.
Sir, what is your opinion on cycloplegic refraction during the school screening camps?
If the refractive error is significant. But for that, there is one easy way of doing is, in the REACH project, they have first screened vision just like that, and then they screen vision with a plus 1.5 cylinder. So if someone is using a lot of accommodation, then when you put plus 1.5, he or she is still able to read it clearly. So at least that takes care of a fair bit of accommodation. But in most schools, at least in Maharashtra, where I know, they would want a parental consent before a drop is put in. So especially in the government schools and the corporate and hi-fi schools, they will not allow us to put in a drop in a child's eye unless the parent is not there or there is no consent, and which is, well, the right thing to do.
Actually, I have seen in Kerala, they try to bypass this thing in a different way. So the counselor goes to the school when the school screening is happening. They directly talk to the parents, taking phone numbers from the child's identity card. They talk to the parents and take consent from the parents over telephone. So that is one way I have seen in Kerala.
Then we'll move to the next talk by Dr. Deepti Joshi from Hubli, Karnataka. She will be speaking about the demand-supply disparity. So the problem actually exists. We have a lot of demand for pediatric eye care at the community level, but what is the supply scene? I think she will be telling us about this disparity.
Good afternoon, everybody. So this IC is basically about the pediatric blindness. Why only about the pediatric blindness and not the adult blindness? The statistics, the near total statistics of WHO states that there are about 1.4 million blind children in the world, out of which 45% are avoidable causes. And the blind ears caused by the pediatric cataract is pediatric causes are second only to the adult cataracts. Pediatric blindness, as we see in our OPDs, is not just associated with blindness. Most of the time they are multi-system. For example, take up the rubella cataract. I just see the cataract, I just see the retinopathy, and I don't look at the cardiological aspect, neurological aspect. Doesn't make any sense in the development of the kid or the socio-economic impact it has us as a whole on the country. In fact, WHO has stated that the pediatric blindness, how do they estimate pediatric blindness is by estimating the under 5 mortality rate, and that gives the estimate of the number of blind children of that particular country. So you can imagine what is the impact of this pediatric blindness on the development of our country as a whole. So the final sentence which was put up in Vision 2020 was, if Vision 2020 targets are met, the global prevalence of blindness will fall from 7.5 per 10,000 children, which was in 1999, to 4 per 10,000 children in 2020, declining number of blind children to 8 lakhs. Oh, so now we are already in 2018. So have we even come halfway through it? Seems a bit dull. Why? Basically because of this question, this thing, that is the demand-supply disparity. We have a large demand, but then what we are providing is absolutely not meeting the demands. That's my topic for today, the present pediatric blindness relief scene, demand-supply disparity. So let's touch one by one, the most important being the refractive errors. Just now Dr. Parikshit sir has gone through most of the things, but 18% of the total curable blindness is refractive errors. And India is basically an young country with about 44% of the Indian population is being less than 16 years, of which 8.5% is of the urban and 6.5% of rural children need specs. And obviously with all this myopia, so all this, we know that why they are coming up, because the children are more and more accommodating, more of mobiles, more of laptops, more of tablets. Myopia is basically an high rise among all the children. So detecting this refractive error is under the mercy of our school screening, and that mainly falls under the optometrist, or as we know in our Karnataka as MLOPs, that is the mid-level ophthalmic personals. But are we really meeting these demands? How many optometrists are being produced every year? How many of them are coming up every year? And when they come up, how many of them are ready to work in an NGO or in a government setup comes as a most important. When you put in an effort, you want the money back, and most of them end up going into that of a private setup and they start working up over there. So then the next question, some of you may argue, there are school teachers who have been trained. Like in Bangladesh, there are key informants who have been trained. They're actually screening the school children and they are referring kids to the various other institutes. Yes, I do agree, but still there are few drawbacks despite all this work being done by school teachers and key informants. What are these drawbacks? In rural setup, school going population is not the representational population. There are so many kids who go out from the home in the name of going to school, but they don't go to school. They end up somewhere else. They are missed. There are so many kids who are having so many other multi-system problems who don't go to school because they are not able to go to school due to some other problem. So again that kid is being missed. And glasses, once we give the glasses, I think the whole lot of discussion has happened, the compliance, the follow-up. So that is the huge gap in the rural scenario. Urban scenario, we just discussed, it's the social stigma. There were two parents who came to me recently. The son was my daughter's classmate, so you can imagine he's just in LKG. The moment I said that the son has glasses of about -1.5 cylinder, the mom cried as though the child has got some huge disease which cannot be cured at all. So an educated person in the total urban scenario, the mom behaves in this way. You can imagine what is the rural setup. These are few stigmas which leave a huge gap when we consider that of the refractive errors. The next, cataract. With the corneal blindness going on reducing with vitamin A supplementation, the measles vaccination supplementation, the most important and the most upcoming is basically the cataract blindness. So somebody said, seek and you shall find. That is case finding. Find the case. That is where lies the major problem and the demand disparity in cataract. Who will find the case? It's a bit difficult. If you go to a preschool going age group, a small child, zonular cataract or maybe a small posterior polar cataract, such cataracts, until and unless it is a total or a membranous cataract, most of the time goes missed. Babies don't complain and parents don't realize that, at least in our setup we have seen parents bring them only at around 9 or 10 months of age, even though the child is not fixing right from 3 months of age, because the parents somewhere believe as the child grows, the child will get better. Once the child is of a school going age group, by the time the child starts to complain, he should be somewhere around 624, 636 or 660. So that means for the past 1.5 years, he's already been staying with the cataract and he has not realized the importance of it. So that is the case finding is one of the supply disparity. Next comes, chalo, we found out the case. What happens about the treatment part? WHO states that nearly one pediatric eye care center is needed for 10 million population. But are we so many pediatric ophthalmologists available? No fellow in the given scenario, no person after their MS directly wants to take up a pediatric opthal fellowship due to so many obvious reasons, leaving a very few people. So where are we? So the number of doctors are comparatively less. Even if there are the number of doctors, the next question comes, the surgery. Who pays for it? If you go ahead with I'm not going into which company what, but if you actually look into that of the insurance companies, what they pay is not sufficient even for maybe a performance of a rhexis in a pediatric cataract. Adult cataracts are getting paid way more than that of pediatric cataract, but in our setup, we need vitrectomy. We need general anesthesia for each kid, general anesthesia for each eye. In fact, twice GA for a kid with a pediatric anesthesia. Who is paying them? So there is a cost barrier, and again we are not meeting the demands. Consider the fact that the surgery is done. Now what about the rehabilitation? Glasses, contact lenses, secondary intraocular lenses, the follow-up, the number of times they have to keep coming to us, the visual rehabilitation, the visual stimulation exercises, again there is a disparity. Parents are not understanding that just a cataract surgery meets all the things. Our work starts after the cataract surgery, and due to the travel, their losing of 1 day of their wage, parents don't come for follow-up as we advise to them. So again the gap which lies with the cataract. The next is basically the ROP. So Anand Vineka sir has already touched the topic. So with a better neonatal care, ROP has become the new epidemic. But are pediatricians concentrating on the ROP? When there is a neonate in their hospital, all they want is that the neonate should go ahead, should survive, should come up with, better life expectancy, but they are not worried about the eye. Only when the child is being sent from the neonatal ICU, they start thinking, oh, this is a preterm, it was a low birth weight baby, it has to be sent for an eye evaluation. By then, it's already an APROP. So the pediatrician and the patients, nobody, given a fact, not even a well-literate patient knows that there is something called ROP when the child is premature. When they come to us for a checking, they ask us, why have we been sent here? Why did the pediatrician send us here? So nobody really knows much about the ROP. Though a lot is done by the kid ROP, but many of the remote areas are not touched. When done, sir just now pressed, the guidelines of screening had been put forth in 2000, and after that the screening guidelines have not been revised till 2018. So what we need is basically a group approach. The pediatrician, pediatric neurologist, the nursing care, the optometrist, the retina specialist, immunization workers, all have to know the importance of ROP. Somewhere we have to propagate with the refractive error, with the cataract, that ROP is equally important, and the retinal pathology, the child stays with it for lifelong. Corneal blindness, I already told it that vitamin A deficiency is almost eliminated. The most important being the trauma, but the surgery, corneal surgeries, the grafting, the grafts, the supply of A-grade corneas, but the complications like graft survival, the secondary complications like glaucoma, with all these things, even though there is a graft rejection, the parents don't turn up for the second surgeries. Again, the cost, again from our side, the supply of clear corneas. So the squint, the patient stigma, again, the squint brings a good luck to the child, and so the parents don't turn up. Low vision aid, I think Asim sir will be touching upon it. So summarizing, these are few points which are actually playing a huge role in the disparity between demand and supply. The inadequate coverage from the health insurances, parental stigmas, lack of public health tool, the distance, patients staying in the remote area don't want to come to pediatric ophthalm setup, which are placed mostly in a metro cities or tier 2 cities. Disparity between the children and the pediatric ophthalmologist, ineffective trained health workers, commitment from the optometrist, and the last but not the least, we as doctors, we ophthalmologists, we retina specialists, we pediatricians, and we pediatric neurologists. I think the pediatric neurologists nowadays are coming into it with the upcoming cortical visual impairment as being one of the very important in the rehabilitation part. So if all of us work simultaneously, this disparity can be updrawn. So what is the solution? My other co-instructors have already touched upon it. Thank you.
So what's the solution? So I will start with the solution. So the solution is about, it's all about the money. Okay, so for anything, you need to have the resources, you need to have the funding. So a blind child is everyone's responsibility and liability. Obviously, you know the socio-economic impact of having a blind child. So it cannot earn on its own in future. We need to take care of the education. The child has to be, for the family, for the community, for the country as a whole. This is going to be a huge financial liability. So the kind of money that you're going to invest in trying to take care of this blindness makes a lot of sense. Makes a lot of sense. So we are trying to put in a lot of money into adult or geriatric blindness, somebody who's 80, 90 years old. We are doing cataract surgery. We're putting a lot of money into that. Probably the number of his blindness years, in case we don't do that, will be far less compared to a child whose blindness years can be really astounding. So we have children like this who are attending schools today. So we have refractive errors, we have squint blindness, which is basically a unilateral blindness, but still has been pushed to the corner because it doesn't really make any sense to most people because the child is still seeing and attending school. And corneal blindness still is lurking, is one of the very important major problems because of its technical difficulties in the managing corneal blindness. So basically it's a very resource intensive specialty, and the biggest problem is the cash crunch. So the effect, even though there are programs, there's a very poor implementation. So who are the stakeholders? It's basically the family. Okay, for many reasons like social reasons, economic reasons and myths, and they don't have an access to pediatric care. So many times they may not be able to discharge their duty, but obviously the health system has to chip in and try to bridge the gap and try to cross over these hurdles of socio-economic problems. So obviously we do need to, have some kind of points of contact. Anganwadi is one very important area, probably where, because the child is still in a very young age where the child's so-called blindness can result in a permanent scar, can result in a permanent visual disability. So this will be one important area wherein effective implementation of our programs can leave a much better impact. And the primary health center obviously still has to be sensitized that staff they really can do a good job in a proper referrals. Now we have this whole army of ASHA workers who actually are doing very good job in some of the states. At least in Karnataka, we have a very good experience with ASHA workers. The school teachers have been always, Dr. Parikshit has alluded to it, one of the very important weapon in our armamentarium where we can use them very effectively, because the parents are, I mean, many a times they do listen to the teachers, especially in the rural setting. So the school work teachers has to be sensitized, and the vision center technicians, the pediatrician, of course, for both in the rural urban setting, the immunization staff, and all these actually. But where are the money coming from? Basically, we have some of the international NGOs like Orbis, which has been really focusing on very aptly the childhood blindness as a focus area. And we have the government set up, both the central and the state government. But even though the kind of allocation to the overall health in most of our budgets is very abysmal, but the amount of coming to probably eye care is still less, and to pediatric eye care probably is very disappointing most times. And we have the CSR funding, and we have the private sector also chips in. So these are all the different areas in which probably we do have the resources. But the whole important hurdle is being that there is no mandated screening that still that doesn't really find a place even today. So unless we really make it mandatory, as we are talking about the preschool placement, like before the child enters the school, if there's a mandatory eye screening, then that can probably screen a lot of things, refractive errors, squints, and other problems, amblyopia. Similarly, at the Anganwadi, if there's a mandated screening, annual screening, that probably can be very easy for case finding. And basically, each state has probably their own populist programs. Many times they don't reach the logical end. Most of them will be actually a new government comes and they will roll out a different scheme altogether, try to alter the existing scheme, and sometimes they collate many schemes into a different name. So there are multiple names. In fact, there are so many schemes, at least in Karnataka. So many of the officials actually do not know any details of that. Like when we went to the neighboring district of Karwar and asked for a Bala Sanjeevani scheme. Okay, they really had to dust out a lot of papers and take things out from where they took really 3 days to really find out what that scheme is all about. Even though it was supposed to be, they must be running that scheme, you know, they really had no idea, no clue about are there any funds under this particular scheme that even the government has actually rolled out. And many times the government rolls it out, but it doesn't really go till the field level. So basically, if you have, you need to probably different allocation for different diseases, different problems. But what is ideal is a national policy which integrates all the stakeholders. So we are actually many times reinventing the wheel, duplicating our services and our policies. So if we can make childhood blindness a priority area, as I told you, for obvious reasons that we are converting a curable blindness into an incurable blindness just by the delay, and also in terms of its economics, probably that is the best return on investment on eye care is in pediatric area. And obviously we need to have some kind of an adoption by different institutions, because we have so many institutions of repute in India. If they can actually adopt a particular geographical area, then probably we can have some kind of an equity with quality. The whole problem in pediatric eye care is equity, because a lot of areas are unserved or underserved, and there are also issues of quality. And we need to really look at which are the areas which have very higher prevalence. So we should have a childhood blindness component in every program and trying to cover. And basically I told you the continuity of care, because we need a strict follow-up, we need a lot of ancillary support from various departments. So basically if we can integrate all this, we can actually have, that is the basic challenge. There are a lot of skip areas, and different aspects of childhood blindness have to be tackled differently. So we have discussed all these by the previous speakers, and well, this is something which very close to my heart, and many of the people working in this community pediatric ophthalmology have found a lot of help from Sarva Shiksha Abhiyan. But this is something which most people, it has been one of the underutilized or underexploited scheme by most areas. And also there is some kind of an apathy in some states about the proper implementation. Even though they have an excellent network of officials and field level workers, there is a parallel system. Just like we teach, the Department of Public Instruction or Department of Education or Human Resource basically takes care of teaching the children. There's an entire network of people who are dedicated to Sarva Shiksha Abhiyana implementation. Of course, the kind of effectivity of these programs being implemented in different states do vary. Okay, there are a lot of states which actually do very well with the Sarva Shiksha Abhiyan, but this program is something which has given excellent results by, well, basically when they join hands with some of the NGOs, some of the private organizations. So this is one of the very good example of a public-private partnership, because the NGOs have the commitment, have the expertise, and have the know-how of how the field works. At the same time, this government system has the teachers under them, they have resource persons under them, and the school and the basically the Anganwadis, okay, can be very effectively brought under this particular screening programs. So the only thing is we need to probably avoid the duplication. Many people doing the same job, and this is the potential. But anyway, as I told you, like everything keeps changing in our country. There is an effort to unify all the schemes, the different schemes for different levels. So there is a universal healthcare is, that is the probably which is arising in the horizon, and probably such a thing has both advantages and disadvantages. Probably if you unify too many things, then the actual focus on childhood blindness can actually evaporate and can become less important. But at the same time, if we can probably unify all the scheme, that there can be a better integration of stakeholders, so that a better implementation can happen. And this RBSK, of course, this scheme nowhere works in most of the states now. Rashtriya Bima Swasthya. This is Karikram. This is which also had an element of pediatric thing, because they were actually getting some amount of financial help for treating children even. So we need to basically see that the resources which are coming into pediatric ophthalmology at the community level need to integrate, and basically it has to, all the stakeholders have to prioritize childhood blindness so that more money can flow into these areas. And we'll still need very clear guidelines, like and we need to basically convince the policy makers about keeping the childhood blindness, because which is probably the best return on investment. I think as I always told you, of all the probably the most satisfying thing in our whole ophthalmic practice or life is trying to restore a smile on a child's face. Thank you very much.
Thank you, Dr. Krishna Prasad. And Dr. Krishna Prasad has been having this course for last 4 years in a row, and he always gets us and every time puts us on a new job to do it. And I would now request Dr. Sil, our final speaker, to speak on his low vision aids and what can be done for that. Yeah, Dr. Krishna Prasad has a presentation to give in another hall, so he'll do that and he'll come back. And after this, there will be some time and we can have.
It's not work. Oh yeah, the Rashtriya Bala Swasthya Karyakrama. I'm actually working for the government in Karnataka. I'm attached with Minto Eye Hospital. So actually, how it's working, like it's working very well now. In the past 2-3 months, particularly. So there's one RBSK coordinator attached with RIO Minto in Bangalore. So these primary healthcare workers, like the doctors in the PHC and the CHC. Particularly, I work with the squint and oculoplasty, so it's actually easy. So they send a picture on WhatsApp to the coordinator, and then we advise the doctor back as to when they can send the child. Like summer emergency, like this month we had about 10 such children. And currently the exams are there in March because we are going for elections in Karnataka. So sometimes we decide like that. So if it's like a refractive error in an older child, then I ask them to come back after the holidays are over. But if it's an unilateral younger Anganwadi going child, then the exams are not a matter. So then I ask them to come the very next week. And it also helps us to schedule general anesthesia also, so that we don't have crowding at one point and then we do not have any cases like that. So I think this RBSK is working out very well, along with the district early intervention center, so DEIC. Actually today we are having the first anniversary being celebrated in Bangalore Medical College. So it's like working very well. Thank you.
Thank you for your feedback, doctor. Thank you.
Okay. Good afternoon, everybody. At the outset, I would like to thank Dr. Krishna Prasad for inviting me and especially giving me the topic. It's all about helping the visually impaired children. So when comes the question of helping, it's a great responsibility on our ophthalmic fraternity to render help, because it's not that people will come to us. We have to reach out to people, and there lies the major part of our responsibility. I would like to share our experience. So as per the definition part, now there is no restriction. Earlier we were restricted to 6/18 to 6/60 by definition, but any child with any amount of residual vision is a candidate for low vision rehabilitation. So if you look at the magnitude, in India it can be said that roughly about 3 per 1,000 children, 2 to 3 children per 1,000 children in India, they need some kind of low vision assistance. So barriers, so far we have discussed about the barriers. I think the most important barrier is the awareness. Something like low vision intervention exists. It's not known by neither the parents nor the professionals. And if I recollect one article published from L.V. Prasad Eye Institute, there they studied about the awareness amongst the ophthalmologists working in the same institute. It was done by the low vision department, and they found a gap. So forget about other organizations inside the country. And there's a poor linkage between the pediatric service and the low vision service. That's why the timely referral are not happening. And most importantly is the follow-up is suffering. And then big question of availability, where the parents will take their children for low vision services. Centers are very, very few. And if you think of the vast country like India. And last but not the least is the affordability. The devices, the optical devices especially, they are very costly. So unless there is some kind of financial support for the children who cannot afford, for the families who cannot afford, it is just demonstration of the devices and then not using the devices actually. So another taboo is a social taboo, because if you see one child is using a telescope, then the child is identified as a person with some disability. That might not be liked by the family. And compliance is a major issue among the children. And the other thing is, the low vision device is not like spectacle. We prescribe spectacle to someone and forget about it. Low vision device is something else. Unless the child is encouraged to use the low vision devices, the child initially might not like the devices. Once the child feels that this is actually helping him or her to see and helping him or her to perform better, then only they will be using. And during that period, encouragement is needed, proper training is needed. And follow-up. Low vision intervention in a child is not an one-time affair, it needs follow-up, and that is actually not happening. And if we look at the quality issue, there is unhealthy commercial interest shown by some of the commercial houses. So they make the price, put the price artificially very high and make it unaffordable and tries to get lot of profit out of it. And the picture that I have shown, this picture was taken in one low vision distribution ceremony. The parents were looking at what all devices this gentleman's son got from our side. So he was convinced with the magnifier. The letters are appearing larger. He was convinced, but this fellow was not convinced with the telescope. He was holding the telescope and he couldn't see anything, and he was saying, "What for this has been given?" And we noticed that he was holding the telescope in a reverse way. So when we just corrected and helped him to focus some distant object, then he was very delighted. "Oh, that signboard I cannot read, but with this I can read. Okay, definitely this is going to help my child." And that's it. He was convinced and he took his child. So unless this small part we don't take care of, intervention becomes almost zero. If the parents are not convinced, they will not allow the child to use it. And extremely important is starting the process early. Early intervention helps in better development and sensory motor skills. Most of the times, if we have a child who is not able to see, we take care of the child differently. Most of the all our children, they learn lot of things by seeing. When they are not able to see properly, then they need some kind of special assistance, which is not very difficult, only needs training. But the problem is, who is going to train the mothers how to help the child to grow up better like other children? And early introduction of low vision devices makes lot of difference in the reading ability. That we have done a study in our institute, and few years back that study was awarded in this All India conference. So if we look at, just as an example how it helps, if we look at the issue of reading speed, that normally a reading speed is 100 to 150 words per minute. In low vision patients, this speed varies depending on the type of ocular pathology. If the central vision is good, then reading speed is better. And reading speed and the comprehension power decides the mode of child's education. So if it is assessed early in the life, we can decide what kind of education the child is going to get. And the special education in India is something not well organized. In most special schools, for the visually challenged children, it's a uniform prescription of Braille. I have seen children with albinism, with low vision devices, they can really see very well, but we see that they are reading Braille. They are not supposed to read Braille. And when we give them the text, they are not that good in reading. They are much faster in reading the Braille than the text. And very few schools have a separate arrangement for teaching low vision children differently. So this results in unfamiliarity with the print, even with the useful residual vision. So I remember my wife specialty is low vision. So I remember one child, I got that child in a camp, and we did cataract surgery, bilateral cataract, and that child had recovered good amount of vision, useful vision, but she was admitted in a school for the blind and she was reading Braille. I remember her name was Uma. So when she came to the clinic for low vision device, low vision assessment, my wife was saying that we could improve Uma's vision up to N8, but her reading speed is so slow, is useless. Around the same time, one boy he just got admitted into higher class. Possibly he passed out and got admitted in college. So he came, and he was very delighted. He never studied in school for the blind. He used to take help of the friends. Somehow he used to read the book. He was very much familiar with the prints. So when the low vision device was given to him, he was reading very fluently. So then we did the study, and we saw that the children who were introduced to print earlier in life, they had a better reading speed. So in Indian scenario, whatever I said, that mostly it is Braille, universal Braille. So that is one hurdle. We hardly have any scope for individual education planning for the children. So what happens, till they are in the schools, they read Braille. While writing the exam, they take help of the writers, they take help of the readers, but when they go out of the schools, they become helpless. So that really frustrates them. And here comes the role of the ophthalmologist. Interventions are very customized and disease specific, and it's not trial and error with different optical devices. We have some perception about low vision devices, like we sit with a box of optical devices, try this or that, and whichever is liked by someone, we prescribe. It's not like that. And it's always a mix of clinical management and assistive technology. So like if we look at this child with anophthalmos, so we should not waste time. We should start early intervention and then get the child admitted in either special school or integrated education. Microphthalmos, severe grade of microphthalmos, they have good, useful vision in earlier part of life, but later on they don't have. And for moderate microphthalmos, they do very well with low vision devices. Then corneal cases with vitamin A deficiency, vascular scars, they are not good candidates for keratoplasty. Always we don't get good results, graft failure chances more, but for hereditary dystrophies and keratoconus, the success rate is much better. This child got this eye operated, and he got a good result. And usually the dystrophies do better after keratoplasty. And then glaucoma, earlier surgical management, follow-up is a must for them, and ultimately after the glaucoma is controlled, the low vision devices work well for the children when they grow up. And aniridia cases run in families, very strong hereditary autosomal dominant disease. Clinical surveillance is very much needed, whether it is turning towards glaucoma and all, and they do well with low vision devices. Retinitis pigmentosa, since we know that the vision is going to worsen in future years, we have to plan for the future. So they may be taught Braille additionally. When they lose the sight completely, then Braille can help them. Then cataract also, that most of the times we get them late, so we need to have low vision support after the cataract surgery. And something like ptosis also, it can be taken care of nicely, because that also causes some difficulty in sight for children. Albinism, low optical devices, and a combination of optical and non-optical devices. Non-optical devices have a lot of role in cases like albinism. So in example, what Dr. Krishna Prasad was telling in Sarva Shiksha, I am just going to what we have achieved. I am not going into detail. We did in 10 districts of West Bengal, and project was divided in 7 steps. We first trained the special educators. Special educators have much more sensitivity than, they are much more sensitive about the issues of the blind children than the regular teachers, because they are focused on the disabled children. And then they identify children in their place. We send our team at the grassroots level, at the block level. Then they screened again. Then ophthalmologists saw the children, and the children who needed surgery, they are brought to the hospital. And for all the children who needed low vision devices, we make a packet for each child, and give it back, give it to them at the district level. And do the follow-up. And follow-up mostly we do through those teachers. And teachers are regularly connected with the parents. So, like, it does have strong component of advocacy. Here in this picture, this gentleman and this lady, politically they are arch rivals. They don't see each other, and most of every month possibly they are in the newspaper. They are fighting against each other. But when it comes to the low vision project, at least they sat side by side for the cause of children. So that's why I have included this picture. And here, from 2009 to 13, we could reach about this many children, close to 5,000 children, who really needed some service. And this surgery, I would like to. It's not playing. Okay, I can skip it.
Just see if you can play it, because we'll finish in the next 5 minutes.
What happens? So just look at the pupil, almost non-existing pupil, both eyes, because needling was done in some medical college, and that was not the proper method of cataract surgery. So ultimately we had to do some pupilloplasty and then clear the visual axis and put an IOL, and that actually enabled the child to go back to the school again. So low vision service is not centered around some devices. It's a mix of clinical judgment and the use of devices. So the guidance should come from the ophthalmologist. So these are the group of children brought from one of the districts. So if we go out of our boundary, we can really help them. Thank you.
Thank you for such a wonderful presentation, Dr. Asim. I think he deserves a big clap. Okay, we have just another 4 minutes before, because the next session starts at 1:30. So at 1:25, we have to give them the hall. So we can still take a couple of questions, if there are any. Okay, so we can see that the session is closed, and we've closed it about 5 minutes before time. Thank you for being such a wonderful audience. Thank you.